So, what about the last area? We are treating the lower incisors. We have, in this case, some buccal displacement of the root, but before saying that with orthodontic means, we can push the root back to more lingual position. This is something that it's also true when we treat single type gingival recession. We have to check with the cone beam that there is some bone lingually. Because if orthodontically we risk to move the dehiscence from the buccal to the lingual aspect, we don't have to make any orthodontic treatment before. Because to treat a lingual dehiscence is much more complex, let's say very, very difficult, than to treat a buccal dehiscence. So when orthodontic therapy cannot be done to improve the situation of the soft tissue, obviously we have to manage the surgery. And what we said yesterday, we can make always a corneal advanced flap independently if there is no keratin incisio apical, provided that there is some keratin incisio lateral. This is the key. Keratin incisio lateral, where you make the horizontal incision, is the key to give keratin incisio to the surgical papilla that will be advanced above the anatomic desepithelialized papilla, and the stabilization of the flap in the corner position depends on the first intention wound healing, surgical above anatomical papilla, and it is completely independent on the lack of keratin incisio apical, because the lack of keratin incisio apical can be compensated by adding a connective tissue graft. In this case, I have really bad keratin incisio apical to the two central incisors, but I have good quality of keratin incisio lateral. In the lower incisors, the technique is never an envelope flap, because with an envelope flap that goes from canine to canine, you advance the flap, but you cannot make it vertical. You cannot attach it to the periosteum. You cannot make the verticalization of the flap. So for the patient, it's very difficult to maintain the post-operative course if the lip is perpendicular to the root. This is something that you always do when you make tunnel procedure, that you cannot make vertical incision and you cannot make the verticalization of the flap. So in order to make the verticalization of the flap, you need two vertical incisions to give verticality to the flap, because the alveolar mucosa that is taken from the lip can be attached to the periosteum that is completely free from muscles, and being attached to the periosteum can be verticalized. So this is the deep incision, and this is the superficial one. Here, there is no problem to make the deep incision. There is no problem to remove the muscles attached to the periosteum, because there is no nerve in this area. And so in this area, where there is no verticality of the vestibulum depth, we not only have to make the deep incision in order to expose 5 millimeters, we said, 5 millimeters of periosteum apical to the most apical extension of the root exposure, but we also have to remove the old tissue that was previously attached to the periosteum, like we did for single type gingival recession, so that this periosteum is completely free from muscle. So this is the incision perpendicular to the bone that removed the 5 millimeters of muscles that was inserting onto the periosteum apical to the root exposure. So if you remove this amount of submucosal tissue from the area to lateral, the whole area will have only periosteum free from any muscles. And when we make the periosteal anchorage suture, your flap remains very, very nicely vertical, attached to the periosteal bed. So what we did for single type gingival recession, which means removal of the periosteum, not only laterally, but also apically to the root exposure for 5 millimeters of periosteum with no muscles, should be done also for the treatment of multiple. Now it's more than enough. You see that there is no more muscles here. There is only the periosteum. There is a very, very good control of the bleeding. I can apply my graft. I can place my papilla in the final position with the position suture. Then I close the vertical incision with the periosteal anchorage, where the periosteum is completely free from muscles thanks to the removal of the submucosal tissue. So this is the most apical periosteal anchorage, which is done with a 6-0 suture. And once the vertical release incision is closed, you go back to the papilla and close them back, because now that the vertical release incision is closed, I can finalize the sling suture, sling around the lingual aspect of the tooth, and make a very, very good adaptation of the surgical above anatomical papillae. So the sequence of the face is exactly the same of single type gingival recession. And also what we did for single type gingival recession, namely removal of the submucosal tissue on the periosteum, verticalization of the flap, positioning of the papilla before closing the vertical release incision, and once the vertical release incision is closed, go back to the papilla, has to be repeated for multiple. So how much graft do we need? No more than 4 millimeter strip. So very, really minimum amount of connective tissue graft despite enormous exposure of the root. But this is the quality of the graft I ask you. This quality of the graft, it's so thin, it's so collagen rich, dense, that follows perfectly the different position of the root and of the papilla. But when you see your clinical cases, when you are at home and you see and you make a picture, or you see your patient after connective tissue graft application, what you should look at is that corner to the connective tissue graft, there is always triangular red area, free. Free for what? For the surgical papillae of the coronary advanced flap, because one of the biggest mistakes is that you suture the graft without considering that there should be also space left, more corner, for the surgical papilla of the coronary advanced flap. And if the graft covers the papilla entirely, there is no blood supply for the surgical papilla of the flap shrink, the graft exposed, and everything is failing. So it is this area, red area, coronal to the connective tissue graft, that is the area for the tight adaptation of the surgical above the anatomical papilla that will make this flap remain stable, covering the connective tissue graft, and most important of all, verticalized. Remember the baseline situation? 10 millimeters of recession, no keratinized tissue, no vestibulum depth. Now we have about 7 to 8 millimeters of verticality. Why? Because this is an alveolar mucosa so thin that can be applied to the root with no more muscles in the middle, and this makes my flap very vertical, but makes also the post-operative course very, very easy for the patient to follow, because the patient has the verticality of the vestibulum depth replaced and don't go home with the flap perpendicular to the root. That is a situation that really it's very, very, very difficult for our patient to keep stable. So this is the 1-year outcome. Look at the verticality of the vestibulum depth. This is the 3 years outcome, and only by pulling the lip you can see that this tissue becomes white because of the ischemia of the alveolar mucosa. But the amount of keratinized tissue you gain is in relation to the biology. Where is the mucogingival line? But you don't care where is the mucogingival line. What is very important is the tissue. It's so dense, so collagen rich, that will resist to gingival recession to form, even if the patient brush with an iron toothbrush. But what I want to tell you is that from an aesthetic point of view, it's very important that when the patient, this is the thickness of the tissue and the morphology of the tissue, you have after 5 years of coverage with increase in the soft tissue thickness and the complete coverage at the level of the recession. This is the 7 years. But when the patient look herself, there's no difference in color, texture, and surface characteristics between the treated that were between the old treated teeth and the adjacent teeth. This is what we want. While when you pull the lip, you see the thickness of the tissue because of the ischemia of the alveolar mucosa that gives you the idea how stable is this tissue. That's why the connective tissue graft must be completely covered. Completely cover the connective tissue graft means that you don't see the difference in color, texture, and surface characteristics, but in terms of function, you have the dense, collagen-rich connective tissue coming from the palate that is working below, and this preventing gingival recession to form or to come back. And this is the very, very long-term stability of this case, and this is the 7-year, I don't know, coverage and increase in the soft tissue thickness in a very complex situation because most of these roots were completely outside of the bone.